Welcome to Plain Talk. Happy to be with you. And the government shutdown continues. Although our governor in here in North Dakota later, well, I say this later today. We're recording this on Wednesday. You'll be hearing it on Friday. So by the time you hear this, you'll have heard the announcement. But the governor's got some plans for helping furloughed workers in the state of North Dakota, which I think is very interesting. We'll talk about that a little bit later in the show. Earlier this week, we had Congresswoman Julie Fedorchak on. And among the various topics we talked to her about was, of course, healthcare. And we asked her some tough questions about our insurance commissioner, John Gottfried, talking specifically about the I don't know what we want to call them, the ACA tax credits for ACA plans that our insurance commissioner says if those go away, it's going to set off a death spiral. Open enrollment is basically now. And he's saying that if we wait till the end of the year, then, we're in a situation where that's not going to help if Congress waits till the end of the year to do something about that. So in the context of all that, we wanted to bring on a healthcare policy expert. Chris Jones served as the commissioner of the North Dakota Department of Health and Human Services under Governor Doug Burgum. He's gone on to work in the Trump administration as an advisor to Robert F. Kennedy Jr., as well as Dr. Oz. Mr. Jones, how are you?
I am wonderful.
So tell us about this situation. I mean, obviously, there's a larger issue with healthcare in America in which it costs too damn much. I think we'd all agree that care is great. I think Americans get wonderful healthcare, but it costs an arm and a leg, and it can create financial straits for a lot of people who need to access it. That's the larger issue. The more emergent, immediate issue is that we've had Obamacare around for a while. People are getting their healthcare plans or health insurance plans through the exchanges, get tax credits from the government. Those have gone away as things stand now. The government is shut down. Congress is trying to reopen the government, but also the clock's ticking, as I've just mentioned, on those tax credits. So, I don't know. Give us a rundown, Chris. How do we get out of this situation? How do we make healthcare better for Americans?
Well, I think Commissioner Gottfried had an excellent interview with you, and he said it's the production, not the payment. It's the price, not the financing mechanisms. I think to quote him, I think he said something along the lines, if we would build a different system if we knew now what we knew then. And he's absolutely correct. And I think what has happened over time. Well, I want to say one thing first. I really appreciate you having me on, because there was nothing more frustrating as a commissioner, and now not being able to say much as being part of the federal government, the impact of the misinformation on the poor and the vulnerable as it relates to Medicaid. Medicaid is already a difficult system to navigate as it is. And for all of this news to go out, whether it's news or commentary or social media, telling people that, nursing homes are going to close, benefits are being cut for kids and individuals with disabilities, is couldn't be so further from the truth. And so even when I was commissioner, if I would see those things, I would privately call them out. This has just gotten way out of control. And for individuals in those population groups to think something is being cut, it's just not true. Full stop. So that to me that's why I loved my job at the Department of Health and Human Services. It actually helped people. It wasn't the big budget, it helped people. And we need to be more efficient in how we do that. And the long and the short of it is, the system is broken. And I think what you have going on here are two icebergs wanting to go in different directions. You have one group of individuals who want to see access to private health care. You have another group that wants to see universal health care. And there's, more flavors under the sun of what that looks like. But over time, it has just grown and grown and grown. And that growth, because government is so involved right now, the prices are through the roof. You can look at Mark Perry, Chart of the Century. The Federal Reserve uses it a lot. The highest inflation is in inpatient hospital services. The next highest higher ed. The next highest, K-12. You look at things that government, and I'm not saying that's wrong, but when K-12 is actually something that is provided on a public basis, maybe it's not as efficient, but it's the best way to do it. In healthcare, is it? I don't know. But like on the short, what we can do, we should have price transparency. Representative Hendricks dropped a bill last session. I worked with him on the first half before I left for DC. It passed the House 89-1 and failed in the Senate. And if you look at the sponsors on that bill, it's pretty interesting. Obviously, he was a first-term legislature, but he sees that these prices have got out of control. So we've got to control the prices. It's not the cost; it's the price.
So, Chris, I want to talk a little bit about that hospital transparency piece, because I mentioned this when we were talking to Steve Forbes last week, and at least one hospital lobbyist didn't like the way I sort of portrayed it. And they said the North Dakota Insurance Commissioner's secret shopper plan was BS and Rob's reporting on it was BS. But the reality is, if I have a heart attack right now, or if I need heart surgery, I can't call the hospitals to figure out what it's going to cost me. To me, that means the free market is not working in healthcare, right? I mean, so...
Right. And I would argue, I mean, just to interject, I would argue, even if it's not an emergent situation, most people are not, like, if you sprain your ankle and maybe you have some time where you could shop around a little bit, most people aren't doing it. And it's not even practical, because a lot of people live in a place where there's maybe one or two or three, depending. I mean, if you live in a larger community, places you could go to even get that fixed in the first place. So there's no market here.
Right. And so I guess my question to you, Chris, being, I think when you're in the private sector, you worked for one of the healthcare providers, then you're at North Dakota or the Department of Human Services. I mean, you know this stuff. I think the hospitals, the healthcare providers say we can't be as transparent because we, cash payers pay one thing, all the, government insurance pays one thing, whatever. Is that BS? I mean, should I as a consumer have access to more information in terms of what I'm paying the hospital or what my insurance company is paying the hospital?
1,000%. Number one. Two, it is complex. I mean, we've created such a complex system. So, I mean, it's not like, pricing, I don't know, Velveeta in the end of a grocery store. But they know it. I mean, if the payer doesn't pay them the correct amount, they protest it, right? I mean, so they do know. And to Rob's point, just knowing basic things, just going in, they know exactly what their price is. So, I mean, again, like I come across at this being a complete Benedict Arnold. I used to do strategy and business development for a very large health system. My goals were to raise revenue or increase market share. And sometimes you do that by buying things. And then when you buy them, without getting totally off topic, you go buy a clinic, you immediately get reimbursed more because it's owned by a hospital than if they were standalone. So, I mean, that's just another example. And there's things going on related to those payments, but that's just another example of why consolidation is happening.
But Chris, just fundamentally, healthcare providers should be able to provide this information, and they should be doing it even if the government doesn't force them to do it.
Correct.
I mean, we're actually going to have somebody, I'm working on it. We're going to have somebody from the North Dakota Hospital Association on, obviously, to give their side of the argument on a future show. I'm still working on that. But one of the things, where they said that the secret shopper thing that Commissioner Gottfried gave us was very eye-opening. When you see such a wide variance in basic procedure, and I understand we're not selling bananas here. One person's pregnancy might be very different than another person's pregnancy. I understand that. This is complex. But on the other hand, I mean, 600%, I mean, the base price is 600%, 600% more expensive to have a vaginal birth in Fargo versus Minot. I don't understand how that, and the only thing in my mind that allows that to happen is nobody's looking at the prices. Nobody seems to care about the price except for the insurance companies. But everybody hates the insurance companies, so they don't get a lot of traction on it. I guess that's the thing that, or if they do get traction, it's from the perspective of the insurance companies denying me care, holding up paying for my care, and that really ticks the consumer off. Even though the reason the insurance company may be holding it up may be for a good reason, because the hospital's charging outrageous prices. I look at all this, and I guess, Chris, I mean, I suspect you and I have the same preference for private sector, free market solutions. But I'm looking at this situation, and it's like, I mean, what do we do other than, I mean, we say price transparency, but is that really going to do it? Or do we need, because that just seems to me like the next step over is price controls. And maybe that's what we need. We already do it with utilities. You know, Xcel Energy is going to, has a big rate increase, and that's going to have to be approved by North Dakota regulators. Is that what we need, are price controls in the health industry?
Certainly don't agree with price controls. Certain states have them. I mean, they have been successful, but I want to put my hospital hat back on for a second.
Sure.
I mean, from that shopping, that secret shopper, in some ways, those numbers aren't really relevant because they don't spend.
That's some of the feedback we've gotten. So why aren't they relevant?
Because they don't really keep track of them other to keep them higher than their negotiated rates, and they don't spend a lot of time on it because patients aren't incentivized to shop either. I mean, even if a patient goes and shops when they have insurance, their coinsurance is still the same, their copay is still the same. So, I mean, really, we consumers are price conscious and value conscious based on what we have to pay. It's kind of like, if you're into the cell phone thing, you get a new phone just by signing up every 2 years or something like that. I mean, but if you actually had to go pay for the phone, would you really do it? Some people probably wouldn't, because it's buried in the price of the bill. So there's that component, and I'm forgetting the backside of your question there. I apologize.
Well, so essentially you're saying that the secret shopper prices that were revealed, those don't matter. Is what you like, the hospitals don't spend time on them? I guess I don't understand that.
Yeah, it's not so much that they don't matter, because if someone is going to cash pay, that's what they're going to tell them.
Okay.
Yeah, so I mean, but there's very few people that are doing it, so they don't spend a lot of time on it. Okay. It's not part of their core function right now, because it's not how services are rendered.
So, Chris, I want to talk a little bit about private insurance companies and my concern about the costs absolutely skyrocketing. And my concern with what Congress has done in the big bill, I'm not calling it beautiful, in terms of the Medicaid changes. I mean, conceivably, it does affect Medicaid expansion, and potentially healthy people are not going to be able to be on Medicaid anymore. The second part of that is the tax credit piece that we're fighting about in Washington right now, which may price people out of health insurance. What I know about health insurance is we need healthy people to buy health insurance because they still get health care. My concern that those two things are going to lead to skyrocketing. Well, prices are already going up because of what we just talked about, but this puts an accelerator on that. And I will put a finer point on that. You mentioned earlier the healthcare costs, higher ed costs, and K through 12 costs. I would say one of the biggest costs that's accelerating K through 12 right now is what they're paying for health insurance. Mm-hmm. I mean, every additional dollar that the state just gave to K through 12 was eaten up by health insurance. So
totally agree.
Tell me where I'm wrong that we're not going to see a huge increase in insurance rates that will affect consumers and will affect private business owners and taxpayers ultimately as well.
Yeah, I'm not in the exchange as much as other people, okay. But my roommate does run the exchange for the federal government, and we didn't sleep much from February through July. So here's the long and the short of it. One, what was going on previously is there were less controls over who was enrolling, both in Medicaid and the exchange. So as of right now, there are 40% of the exchange enrollees who never once touched a healthcare provider that the federal government is paying a premium for every month. Some of those phantom people are in multiple plans. Okay, so that has been going on. So now the way premiums are set is based on prior history and utilization. And because there were so many people enrolled, utilization was so low. And so as they're looking at what does it mean to take these tax credits back out, not only are they losing all of those phantom enrollees, they're also calculating the loss of people who would have gotten quote unquote fully subsidized exchange health insurance, which are going to be your more healthy people. So it's really a double whammy right now because those COVID era tax credits are set to expire. Plus, there has been so many phantom enrollees who haven't been using the system. So it's those two things combined that are really driving it.
How about the Medicaid piece of it, though, Chris, that I know that you were involved in during the big, beautiful bill? I mean, I understand your initial point that this isn't going to affect disabled folks or whatever, but this will affect Medicaid expansion customers, correct?
Yes, as it relates to the community engagement requirements. And again, like, this is the best comparison I can give it. In 1996, there was massive welfare reform that was bipartisan, and it included SNAP and TANF. And SNAP are food stamps. TANF is temporary assistance for needy families. I mean, it's a cash payment. In the SNAP payment since 1996, you've had a 20-hour work requirement. TANF has been 30 hours. And what I can't understand morally is why we think it's okay to work 20 hours a week for food and basic assistance that you need every single day. But to have you work the same amount of time for something you may never use, and that being cruel and unusual humanity, I just can't reconcile in my brain.
Understood. But do you think that will affect people having health insurance and affect the private sector, the private insurance rates?
No.
Okay.
No, not at all. And here's the other thing that, while COVID was awful, there were a lot of good learnings that came out from that. And it's been historically said that there's a cost shift in healthcare because Medicaid and Medicare don't pay the cost of care. That drives commercial rates up. But then what happened during COVID is you could see where people went and they started doing this economic analysis that a few of us truly believe in, is that states that have lower Medicaid and Medicare rates have lower commercial costs. And, more work needs to be done. But I mean, that concept is strange. But when you keep overall costs down, because if you think about the way the U.S. healthcare system works from a hospital perspective, the majority are nonprofit. And 50+% of their revenue comes from government sources. So, and the government sets the price for those as well. So the government is setting the price. So that in essence becomes price is being set before cost. And so based on all of that revenue the health system receives, it then reinvests in other things. And we all know that, we have very wonderful high-end medical services in this country, second to none. But the ROI gets smaller and smaller and smaller. This is my favorite example. When I was at this large health system, we were putting in what were called TAVRs, transaortic valve replacement. It was a very expensive piece of equipment. You needed specialized training. And on average, I shouldn't say this because someone's going to say that's not right, Chris. But I mean, you're going to keep grandma alive an extra 6 to 12 months. They are too sick to crack their chest. So it's those type of, like, what are our trade-offs? And I think that's what's so important. And if you want to compare it to all these other countries and just compare the Medicare, or for that case, Medicaid benefit menu, we provide everything. Those other countries, they do not. And that's a big chunk of it. And then the private market does the higher end services.
Sometimes it can feel like we do have excellent care, but there's so many distortions. And every time we try to implement a new policy, it just seems like we're treating symptoms, if I can use sort of a medical analogy, instead of the disease. I mean, the problem is we have, most Americans are not the direct consumer for their health care. Their insurance company is, really, because their insurance company is paying it. And most Americans have a third party, whether their insurance is through a private, like your employer, or through the government. And then, those policies a lot of times are negotiated by the government or by your business. So the policy is maybe shaped towards their ends and not necessarily your end as the person getting it. And then within the market itself, you have private payers, private insurance payers, but then you also have government payers, and the government fixes the prices, which probably puts upward pressure on the prices paid by non-government entities because the government's going to drive a harder bargain, and they're the government. You can't really negotiate with them. Whereas, the private sector,
Unless you're a drug company.
well, unless you're, yeah. But then and it seems like such a mess. And to me, I mean, and obviously as a free market guy, the solution seems like we need to move people away from third party payers to where you're paying for your insurance, you negotiate your insurance policy, you pay your premiums, you choose which doctors you want to go to, and the choices are yours so that the consumers engage. But the political reality of getting there, nobody wants that. Nobody wants that. And they also don't want to go to the other extreme, which is universal health care, not in America. I don't see that as a practical political solution either. So instead, we're stuck with this hybrid that sucks.
Yep. And I mean, if you want to point fingers at anybody, it's just bad government policy. Everybody's playing by the rules.
What's the right government policy? I mean, right now we're having a fight of, and I'm not to dismiss the importance of the ACA tax credits, but we're having a food fight over that. But that's kind of the trees and not the forest. What is the right policy? I mean, how do we get someplace to where Americans don't have to worry at the end of every year getting whammied by, you're getting a 3% raise, but also your cost of health insurance is going up 4%. So, you're poorer now and you have nothing. You don't get anything more for it.
Yeah, I mean, it's the analogy of too big to fail, because there's so many components to this. You can't change so fast that if hospitals start closing, if the healthcare market collapses, well, that's usually the largest employer group in every state. In 1994, no state had healthcare as their number one employer. In 2024, all but 11 states have healthcare as their number one employer. So it is a huge part of the economy from an employment perspective. But I think doing what people think are these huge changes are really not. And we have to start taking bites of the apple. First, you do transparency. Then you incentivize patients who shop get to keep more money or are rewarded with more money in there. If they're employer sponsored, it goes into their check, or they just get the check back. They share the savings. And then eventually prices will come down because the providers have to compete because patients are shopping. And then you can go from there.
Well, and I think this issue of costs of healthcare and therefore health insurance, I mean, from my perspective, I work for an organization that employs 25 people. Our health insurance went up 10.9% last year. It's not sustainable. We represent 10,000 public employees who, again, every additional dollar coming from the state is being eaten up by health insurance. And frankly, from my perspective, there's a lot of blame to go around, right? I mean, I think Congress is making some decisions that hurt us. I think we've talked about hospitals, and I mean, I don't think
I don't blame hospitals. They're just playing the game.
Yeah, sure. Yeah, that's fair, but have a role in this. And of course, health insurance companies, I mean, we've talked a lot in the past about pre-op and so many different things, but like, I think the average consumer, and maybe I am the average consumer, is just pissed and doesn't know who to blame. And it doesn't feel, and I'm going to get to a question here, Chris, I promise, but like, who should consumers be talking to? Who, like, and how do you filter through? You mentioned at the beginning the frustration with misinformation. I assume some of it might have came from my mouth on this podcast around Medicaid cuts. But how do you cut through what's true and not true? Because frankly, I'm not sure I trust Dr. Oz when it comes to Medicaid, right? Like, you know what I'm saying? Like, we don't trust people. So how do we know who to talk to get the right information? That's a societal question.
You should trust him now. There was only two of us advising him during one big beautiful bill on the Medicaid side. I'm joking.
So I should have
No, I
trusted.
mean,
Okay, gotcha.
um, boy, where do I take that? I mean, you know, again, I mean, all this is historical. Up until World War II, there was no such thing as employer-based insurance. Kaiser messed that up, right? And again, they did it to help employees because of the war effort, but that continued. Then you have 1965 with the passage of Medicare and Medicaid. Very simple programs that have just continued to explode because the system is so complex. And again, we're not even getting into the other complexity of it. We've just made it so complex that the average consumer will never understand it. They never will. I mean, you say 340B, I mean, most people don't even know what that is. I mean, I think when you talk, I mean, people mess up Medicare and Medicaid all the time. Medicare is 100% federal. Medicaid is a partnership with the state that doesn't just do Medicare things. It takes care of, you know, people in nursing homes. It takes care of people with developmental disabilities. It takes care of, you know, half of the Medicaid enrollees are children that are getting services. It's wonderful. But because I mean, everything is into a soundbite, the level of complexity, no one understands it. And it's always been, well, I have health insurance through my employer. Okay, this is what I get. I mean, there's just been nothing there. I mean, what I would like to do when I get out, not trying to, well, I guess I'm selling an idea, but have states for their state employee plans put in what's called a reference-based pricing that says, hey, if you get it at the 60th percentile, anything you save, you keep. And that way the employee has something to shop for, number one. Two, you're not taking any benefits away. They can still go wherever they did before. But now all of a sudden, that's going to drive the industry as consumers go out and say, how much is my knee replacement here? You know, how much is a lab draw here? How much is an MRI here? And I'm going to go, you know, if you're able to travel, you're going to travel. People travel to buy cars. People travel to buy appliances. Why wouldn't you do the same for healthcare?
And I think that would pierce some of the price bloat. I mean, you said a little while, I mean, you can't blame the hospitals. I blame the hospitals. You ever gotten a bill for a $65 pill of Tylenol at the hospital? I'm sorry. I blame them for that. There's no excuse for that.
Well, I will defend him on that one because it's just not part of the industry. It's not where you're going to focus. And until you have control as a consumer, they will focus on it.
Yeah. I mean, my grocery store is going to charge me $200 for hot dogs until I have an alternative to buy hot dogs for what they really should cost. I mean, but I blame them for that. They don't have to do that, but they're doing it because they can, and that sucks. And the insurance companies aren't. I mean, I'm not absolving the insurance industry either. It's just, I feel like there are a lot of people. It's not just complex and difficult, but there are a lot of people taking advantage of the complexity to make a lot of money off the backs of sick people. And I'm not talking, I want skilled doctors to make a lot of money. I mean, it takes a long time for them to develop those skills and to be able to do that. The medical technology and even the pharmaceuticals takes a lot of money to develop some of these things. I'm aware of that. And at some point, somebody has to pay for it. And I'm fine with paying for it. But there's a lot of extra stuff going on here. And it's not for the good of the American people.
We do not have the core Medicaid population. We are not looking at them as our customer that we expect more from ourselves to deliver better services. This is nothing more than a money game.
I know we don't have a lot of time left, but one last question. We have some serious demographic shifts coming up just in terms of age of our population. I mean, the baby boomer generation, I mean, they're the ones working through this system right now. They are an outsized portion of our population. And given their ages now, are consuming, you know, more healthcare as you age. What happens when they age out? I mean, are some of these problems going to become less severe as a result, or what happens then?
Well, I think in the short term, there's going to be more deficit spending because there's still not enough built into
Well, because we have fewer young people to pay for the benefits for all the old people. But I mean, eventually
And-
it's going to
and-
even out, or to where we have the opposite problem, or not a problem again.
No, I don't think so. No, this is going, we're getting precipitously close to having a significant issue with access to healthcare. But I just want to share this because I think it's important to know, you can tell a state's priorities by where they spend their money, right? So, this is just one, I want to just share North Dakota so everyone knows. North Dakota ranks second overall in Medicaid spending per capita. Overall. That's for everything. But we rank 18th in kids. We rank first in seniors. We rank 7th in DD, 27th in the traditional Medicaid, non-ACA, and we rank number 1 in expansion. And it's because 100% because expansion is 90% funded by the federal government. The traditional is anywhere from 50% for most of those, except for kids, it's 78%. And so when the federal government says, we're going to give you more money for this population over another population, that's where states are going to spend their money. And I want to say one other thing is there's 19 states right now that their per member per year, their annual premium for health insurance, 19 states, their expansion premium is more than the average single employer sponsored premium. And in North Dakota, that is $4,500 more per year per member in expansion than your average employer sponsored plan. So, Chad, to your point, not only are the citizens in North Dakota paying for their own health insurance, they're paying way more for expansion.
Chris, thank you for your time.
Thank you.